Now let's move on to discuss some of the drugs used in treating heart failure. The first group we will talk about are the cardiac glycosides. You may have heard this also called digitalis because it is derived from the plant named Digitalis purpura. Here's an image showing the different transporters on the sarcolemma membrane of our cardiomyocyte. Notice how digoxin competes with potassium for the extracellular potassium binding site of the sodium-potassium ATPase in cardiac tissue. By decreasing activity of the sodium-potassium ATPase, we achieve our main goal of decreasing the efflux of sodium. Why is it our goal to maintain a relatively high intracellular sodium concentration? Check out this sodium-calcium pump right next to all this action. This pump will be sad because an increase in intracellular sodium decreases the transmembrane gradient for it to pump out sodium into the cell and calcium out. Decreased activity of this pump leads to an increased intracellular concentration of calcium, which will be stored in the sarcoplasmic reticulum. More calcium means more troponin C calcium binding, and therefore more actin-myosin interactions and cardiac contractile force. Kinda sounds like an ideal drug for someone with systolic dysfunction, right? It sure is. They need contractility. This is not the only mechanism of action of this drug, though. It is not yet completely understood how digoxin increases vagal tone and inhibits the sympathetic nervous system by somehow working in the brainstem. This is helpful in treating atrial fibrillation with rapid ventricular response in a patient with heart failure. The problem in AFib with RVR is that every weird random depolarization that is originating in the abnormal circuits near the pulmonary veins of the left atrium is passing through the AV node and telling the ventricles to contract. This is a really bad situation because the ventricles cannot adequately fill in diastole if they are being stimulated 250 times per minute. By increasing vagal tone on the AV node, digoxin increases the refractory period so that now every single impulse cannot make it through to stimulate the ventricles to contract. This increase in vagal tone on the heart is beneficial, but you must be careful when giving this drug because you can actually depress the AV node to the point of AV block. In addition, systemic adverse side effects of increased vagal tone can be terrible. Increased parasympathetic tone in the GI tract can lead to some common cholinergic digoxin side effects, such as nausea, vomiting, and diarrhea. Just remember, GI with the digi. GI with the digi. Now what about that blurry yellow vision? Well, the rods and cones that are responsible for taking light and turning it into a signal for your brain are dependent on potassium. Digoxin can inhibit the sodium-potassium ATPase on these cones and rod cells. This disturbs normal potassium concentrations and can interrupt normal signaling because rods and cones mainly use potassium to alter transmembrane potential instead of sodium. This is how you get the blurry green color vision associated with digoxin toxicity. How does digoxin lead to hyperkalemia? It prevents the sodium-potassium ATPase from pumping potassium back into the cell and sodium out. This not only happens in cardiac myocytes, but can also inhibit this pump on skeletal muscle. You can just imagine the amount of potassium that it can accumulate in the extracellular compartment, and sodium along with calcium in the intracellular environment. It is this accumulation of sodium and calcium inside that can shift the resting membrane potential to a more positive value. When our transmembrane potential is more positive, it is a lot closer to depolarization threshold. This is how we are at risk for spontaneous depolarizations that lead to arrhythmias. If we are close to threshold at all times, firing early is a definite possibility. We discussed some toxicities, and there are some things that we can watch out for so that we don't almost kill our patient. You can always just monitor the serum levels of digoxin, but that is not a test question because it's just too easy. Digoxin is excreted renally, so any decrease in renal function can lead to accumulation of digoxin in the patient's blood. Now wait a minute, Pete. You just said that digoxin causes hyperkalemia. So why would having hypokalemia put me at a greater risk of digi-overdose? Well, digoxin competes with potassium on the extracellular sodium-potassium ATPase. If the patient is already hypokalemic, then there will be less potassium ions to compete with digoxin at the pump. This can exacerbate the degree of blockade. Digoxin binds albumin, but so do other drugs like verapamil, amiodarone, and quinidine. If a patient is taking both drugs, you can guarantee that one of these three drugs will compete with digoxin for albumin binding sites. This is dangerous because you can potentially displace digoxin from albumin and increase free digoxin floating around. Well, how do we treat digoxin toxicity? We first need to slowly normalize the potassium levels. We need to make sure we can increase the functionality of the sodium-potassium ATPase pump by giving magnesium. Magnesium is a key cofactor for the pump to work. If we're still worried about digoxin levels, we can give anti-digoxin Fab fragments. These directly bind any free digoxin. If all of this fails, then we need to set up for a cardiac pacer, because the SA and AV nodes can be severely depressed from digoxin's ability to increase parasympathetic tone to the heart. A cardiac pacemaker is a catheter that has an electrode on it. You stick it in the patient's veins and push it through the venous system to the heart so that you can send electrical impulses to trigger the rest of the myocytes to contract. Okay, so you have to know this digoxin stuff, so let's reinforce it with a flash quiz. Digoxin is removed from the body by blank excretion. This is a straightforward question, and so is the answer. We need to know that digoxin is cleared into the urine by the kidneys. This is crucial to remember so that you do not give digoxin to a patient that has signs of a decreased renal function. You need to double check that creatinine for any signs of renal failure. A lot of patients with heart problems also have renal problems due to chronic activation of the renin-angiotensin-aldosterone system, so be on the lookout for this. Alright, let's test ourselves. A 78-year-old woman presents to the outpatient clinic complaining of nausea, vomiting, and diarrhea. Her medical history is significant for hypertension, hyperlipidemia, and atrial fibrillation. She states that for the past 4 hours, everything she sees has a blurry yellow tint. Several abnormalities are detected on ECG, including T-wave inversion, an increased PR interval, and a decreased QT interval. What is the mechanism of action of the medication responsible for these symptoms? We've got this. You have an elderly lady with a past medical history of hypertension, hyperlipidemia, and AFib. Now she's reporting nausea, vomiting, diarrhea, and a blurry yellow tinted vision. Her EKG is screaming hints with inverted T waves, an increased PR interval, and decreased QT interval. This is a really straightforward question loaded with information. First, you have to remember which drug has all of these side effects. Then, you need to consider it and recall the mechanism of action. This is how step 1 will be. Instead of just remembering the drug, you need to take it one step further and also remember its mechanism in addition to recognizing its toxicities. Even if you do not remember the drug name, some of these things could trigger your memory. Inverted T waves should automatically make you think hyperkalemia. Do you see an option in the answer choices that could cause an increase in the amount of extracellular potassium? Of course you do. E is the correct answer because it explains the mechanism of how we can get high levels of potassium in the extracellular environment, We are talking about digoxin again here. All of the side effects listed on here should be making you think digoxin, especially blurry yellow vision and the GI problems. It should be noted, however, that the mechanism by which the inverted T wave due to the hyperkalemia is not well understood, and it is a specific and unique finding to digoxin toxicity. Can anyone remember what we normally see on an EKG with hyperkalemia? Right, we normally have high peaked T waves. So remember, if you just have digoxin toxicity, then this will be the inverted wave. But a normal hyperkalemia presents with the peaked T wave.